Dr. Williams, you're a physician, but you're really an innovator. And those two aren't always seen as the same, because I know a lot of doctors, and innovation is the last thing that you would describe that they're doing. They're more following protocols. But really what you're helping to bring forth is the next generation of cancer care. But a lot of what we deal with as we're moving forward is kind of just things of the past that kind of interfere, things that we just continue to do that we don't know why anymore. We just do them as a part of, protocols, what I call protocolology. So what I wanted to do is kind of touch on three things, kind of low-hanging fruits of therapies that negatively impact immunotherapy. So these are patients that could come to us, but they may be patients globally that are going to their oncologist receiving immunotherapy. They may go, hey, I heard Dr. Williams say we need to be concerned about this. Mm-hmm. And so chemotherapy, looking at basically, so chemotherapy, looking at Tylenol and corticosteroids. A little bit of a brain lapse in me, but I wanted to touch first on the concept of chemotherapy, because it's October, it's Breast Cancer Awareness Month, and I came across a study, an article, and it was the title was "Lymphocyte Depletion and Repopulation After Chemotherapy for Primary Breast Cancer." So it was actually a human clinical trial, and two quotes just caught me off guard. Yeah, first one was approximately 30% of breast cancer patients receive chemotherapy, yet little is known about influences of current regimens on circulating lymphocyte levels and phenotypes. Yeah. It boggles the mind, saying, okay, we have the standard of care, yet we don't really know what it's doing to the lymphocytes.
Yeah. Well, I mean, I think overall, any chemotherapies are, for the most part, negatively impacting the immune system. I mean, there are arguable situations where you could gain some synergy, like in a way where, like we see in pancreatic cancers, where short-term chemo combined with immuno might give us a little bit of a boost. Yeah. But if you keep the chemo on, then you start getting real suppressive, because the chemotherapy will suppress the immune system. The question is, like, obviously the immune system has two sides. So you have the regulatory side, and you have the effector attacking side. If the chemo is more decreasing the regulatory side better, then that could actually be helpful. That's why, using drugs like, Cytoxan, stuff like that, cyclophosphamide, like they'll do low dose cyclophosphamide to try to decrease regulatory cells. And so yeah, I think, chemotherapy, a lot depends on how you do it, how you play. But I think in the future, obviously, we'd love to get away from it and not have to use it at all. And, I think that unfortunately, a lot of times for patients, they're heavily chemoed, and then let's try immunotherapy. Well, then, oh gosh,
you wiped it.
Right. Maybe that was not the best way to do that. So,
But that's the amazing thing, because that's the majority of the patients that we see. And yet, Jay, you're still eliciting a significant response rate in these patients where the immune system is just battered and bruised.
Yeah. You're never going to achieve what you need to do with chemo alone. I mean, chemo and immunotherapy is one thing. Chemo without immunotherapy, that's not really a great option. I mean, it's just not, you're just damaging without real, long-term good potential. So, I just don't see that, gosh, we really would like to be able to get away from it completely. I think we can at some point. I don't think we'll need, depending on the patient's situation. Maybe a patient comes with a bulky disease, and then to knock it down, maybe you need to give them a little chemo to knock it down, and then you can get your immune system after it. That might be a situation where you still use chemo. But a lot of these other patients, it surprises me. I mean, to see so many patients, like some patients with human cancers that aren't even that aggressive. Their cancer, the cancer's hasn't even been doing anything 2-3 years, and they're like, oh, we're going to give the patient Folfox and all this stuff. I'm like, what in the world? It's like this heavy duty chemo for a cancer that's not even doing anything. Yeah. So So I don't know. Sometimes I think that the doctors don't have the concept, because there are also different types of cancers, and there are some cancers that are super aggressive, grow fast, they attack, they can take down a patient quickly, and there's these other cancers that grow slowly and sort of hang around for a while, and they don't and those when you start hitting them with chemo, you might make them a little angry. You might actually convert them to be the fast growing one. So it's, you have to be cautious with those cases.
Yeah. It's about the right treatment for the right patient at the right time.
That's right. Yeah.
Precision medicine. And then the second quote, levels of B cells, T cells, and natural killer cells were significantly reduced 2 weeks after chemotherapy. So an abrupt, immunosuppressive state. But B cells demonstrated particular dramatic depletion, falling to 5.4% pre-chemotherapy level. Levels of all cells recovered to some extent, although B and CD4 T cells remained significantly depleted even 9 months post-chemotherapy. I mean,
you obviously when you give a patient chemo, you're damaging them for life in many ways.
Yeah.
And so, it is the wrong approach. I mean, again, it's like, we discussed before about cancer somewhat being like a disease of aging.
Oh, yeah.
The idea that, cancer cells are old and behave old. And so the concept is with chemotherapy is like, oh, you got a bunch of old stuff. You want to kill it. Let's just make it older by giving it chemo. Right? That's what they do.
That statement you make there, I've heard you made that several times. That's one of the more profound statements, Jason, that I think I've heard.
Yeah.
Across, many experts. And aging is being treated by aging the cells, which makes no sense.
Right.
It makes no sense.
Yeah. Yeah. So, it's like your idea is to just make it older. That doesn't, So, whereas immunotherapy, the idea is to make it younger, to make it younger and healthier. And so, that's, what we see with the immunotherapies is really interesting, because you give it to patients and you're making them actually healthier. You're not making them, feel bad. The patients are like, hey, I feel better. I mean, I feel better than I did. And so, when you make their immune system better and stronger, then they actually feel better. And that's the direction we really, want to be able to go with everybody. And I think hopefully the whole medical establishment will get caught up on this and figure it out. But, it's going to take time, because chemotherapy is so ingrained. I mean, they just look at, oh, you got cancer. We got to do what's going to kill it.
Yeah.
But,
what it does.
Yeah. Yeah. And they're just treating sort of short-term results. Like, oh, we made it smaller. Yeah. For a little while. And then it grows again. But, not really looking at long-term, trying to get an actual immune response to get rid of the cancer for good. And so, certainly chemotherapy, we should overall be able to get away from most of it. Be, limited situations that we might need it still. But for the most part, I think we could do everything with immunotherapy.
Yeah, this information on the impact of chemotherapy on the immune system, it's not new. That's the crazy thing about it. It's not new at all. And yet there's, I don't know if it's a resistance to change, but, now we are seeing change in how chemotherapy is being delivered. I mean, you're seeing more lower doses. You're seeing some people do intratumoral immunotherapy, but I mean, if you do a lower dose and do it every week and do it for then 52 weeks, that's really not different. It's just a slow suppression to the immune system versus a big one with full dose over 3 to 6 months.
Yeah. Yeah, there was a study years back. I don't know if I could find it or anything. I mean, I don't know the exact specifics, but I can tell you the rough thing. I think at Kenneth Hopkins, I think they were looking at lung cancer. And they were looking at lung cancer. They took patients with lung cancer, looking at if they got chemotherapy first versus immunotherapy first, right? And so what they found is that if they gave chemotherapy first, they reduced the number of cures that they achieved ultimately by the immunotherapy by 50%. so basically, right. So, the chemotherapy was messing up your future potential for immunotherapy, right? So that was a great study. Obviously, nobody really wanted to pay attention to that. So, but now of course they're doing a lot with the combo with chemo immunotherapy. But the one thing is also, our current FDA approved immunotherapies are very limited. So we're working with really limited tools on that, and so that's why we're still having to use this sort of assistance with the chemo in those cases. In the future, that would not be the case if you have more immunotherapies, which are coming out. I mean, the next year or two, you're going to see more approvals. You're going to see other agents, and then you'll be able to achieve things completely with immunotherapy.
Right. I want to pivot to your corticosteroids, dexamethasone, these kind of things, because we talked about on a previous episode pulse-electric field, tertiary lymphoid structures, but when you look at the protocols of chemotherapy, look at protocols, the nausea prevention related to it, this chronic use of it, but yet when you actually look at the literature related to corticosteroids, they actually impair the development of tertiary lymphoid structures and impairs the immune response. So because this is something that is very common in protocols with conventional cancer care.
Yeah. So, it really confused me when they were giving all these patients steroids, because you'd see the patients get chemotherapy and they get a regimen of steroids. They get dexamethasone or something. And, I kept trying to figure out why. I was like, so I started asking questions. I said, gosh, it must be that the chemotherapies are super allergic, right? And that, if you give them, they have a reaction, so you got to give steroids. And so then I started asking the oncologists. I said, hey, why do you give steroids with the chemo? And they didn't know, actually, right? It was surprised me. I was like, they're like, no, that's just the protocol. That's what we have to do. And I was like, but why do you do it? I mean, is it prevent allergic reactions? Yeah. Then they're like, oh yeah, we think that's what it is. And so, but then I ran into an older oncologist who knew back in the day, and back in the day before there was, as good of nausea medications as are now. And he's like, no, he says, we give it because it reduces nausea. And so basically using the steroids as an anti-nausea medication. Now, obviously, we know we have, ondansetron, Zofran. Yeah, you have Amend, which is actually even has anti-cancer properties. I mean, that would be a way better agent to give somebody for nausea. So why would you give a steroid for nausea? But that's what seemed to be. It seemed like it was just sort of it just been done for so long. It surprised me that I couldn't really I thought it was going to be simple. I thought somebody would say why this was done, but it just seemed like it just got thrown in the protocol from the original studies of chemotherapies, probably in the 50s, in 60s, and just never got taken out. And that's what happened with it. So it was really strange. And we know that obviously the steroids have a huge negative impact on the immune system. As we discussed, they block these tertiary lymphoid structures, which are the hallmark of immune response. Now you're getting all these patients who you're doing these combo chemo immunotherapies. But what are they doing? Chemo with steroids and then immunotherapy. They're undoing it.
Yeah.
So they're messing up their stuff. I mean, this makes no sense. Robert Vonderheide at UPenn wrote a great article about rethinking the use of dexamethasone, and again, it showed you see these benefits. I think it was another study even that, with maybe the lung cancer study as well, with the combo with chemo immunotherapy. The benefit was there with chemo immunotherapy, but only when you left out the steroids. It wasn't there if you used steroids, and yet nobody seemed to give the oncologist that memo, right? They did that, and then everybody's still like doing their same protocol, giving steroids. So, you have to try to avoid steroids. I mean, that's if you can. I mean, there might be situations you have to use them, but if
it's the syndrome sets up, obviously, which is different than tertiary lymphoid structures. But if tumor syndrome hits because of massive die-off and inflammatory response, you got to cut it down.
Yeah, we occasionally we'll give like a patient immunotherapy, and they get a huge immune reaction, and we have to cool them down, and then we have to use steroids. So that's there's times to use it, and then there's funny situations with cancer where steroids sort of like kill cancer. I mean, you see some of these immunological type cancers, some lymphomas. You can inject it. Yeah, I mean, there's even cases before. I saw this more like in horses where they injected prednisone into like sarcomas in horses, and it would kill some of it. I mean, it's like strange type of stuff like that. But that's injecting it into the tumor. That's not giving it systemically. But
I don't know anybody that injects anything in the tumor, Dr.
yeah. I don't know why it's like there's a big elephant in the room. I mean, there's a tumor. We should not mess with that, right? I mean, that's your main problem, but no, we should not touch it. That makes no sense.
Can you tell the story? Sorry to interrupt. When you were, I think it was, they were doing they were going into the tumor with a needle, and I don't know if it was for a biopsy or something. And then you go, what can't we inject something into that?
Yeah. Well, the thing, for me, it was initially because I was doing, research in mice, and we were injecting the mice, injecting their tumors, and it was curing their tumors. And I was like, this works really well. Like, we're curing all these tumors. And then when they went to take the study, I mean, I followed it. Normally, I guess people wouldn't follow this, but I followed like what happened. I was like, okay, what happens? They took it in the trial, and they give it to the patients. They're giving it intravenous. And then and I asked the guy, I said, hey, wait, why are you guys giving it intravenous? I was like, we injected into the tumor. And he said, but that's not how we give it. And I said, wait, but we injected into the tail vein of the mice, which is the same as intravenous. It doesn't work. It only works when you inject in the tumor. So when you do it that way, it's not going to work. We know it's not going to work. It didn't work in the mice. And yet that's what they did. They took it and transferred it that way. And so yeah, cancer, it is a systemic disease, but you need to hit it in multiple fronts. I mean, to go and throw something from way away and say, let's hope it gets there and makes it to it and gets it, that makes no sense. I mean, you have to hit some into the tumor. If there's tumor that you can target, you should go after it and look if you can biopsy it, which, cancer patients know they have cancer because they had a biopsy, right? That means you can inject and stick into the tumor. Yeah, when that's why I became a radiologist. Otherwise, I would have been an oncologist. But oncologists can't stick needles in people. So, I mean, they should, but they should learn it eventually.
So then here's a I'm going to deviate just a little bit. So in the future, the pillars right now of cancer care, conventional cancer care, are surgery, chemo, radiation.
Yeah.
Yeah, we're talking here about low-hanging fruit of things that counter immunotherapy. Here we're talking about corticosteroids, but might we reach a time frame where surgery, chemo, and radiation are rare rather than?
I think that they should, yes, never happen. All of it. I mean, I don't think we should be operating on these people. I don't think we should be radiating. We shouldn't be chemo. Nothing. You identify cancer. You say, okay, that's probably cancer. You go into it with a needle, and you can treat right then. You can sample right then. If you want to confirm it's cancer, and you do it that way, and you don't disturb it significantly. You do it in a minimal way, and you do it immunologically, and get the immune system to see it, and you never have to cut it out. You never have to do any of those things. You just say, okay, there's the cancer. We're going to make the immune system see it and go away, and the immune system fix it, and you didn't have to, there's no surgery. That's just crazy.
Here's another concept, because this is what I've also seen now working with the team at Williams Cancer, which, by the way, the team is amazing, but our patients don't just see tumors go away. Their quality of life improves as they go through therapy. And when you look at surgery, chemo, radiation, it's not just experience. You actually look at the studies of quality of life measures. They're not good. Yeah. They're not good at all. But our patients, their quality of life goes up as they heal.
Yeah.
I mean, it's insane.
Yeah. I mean, the thing to me is I always, want to be able to treat cancer and leave the patient intact. Not having to cut out their body parts, like not having all this stuff. I mean, it's kind of like going fight a war. You take your men, and they all get their arms hacked off, legs hacked off, all this other stuff. But we won. Here we are. We all messed up. That's not what you want. You want to be still the same, right? and that's what we want in cancer.